Hi, I'm Vic Perri. I'd like to begin by acknowledging and paying respect to the past, present and emerging traditional custodians and elders of the lands upon which we're all meeting today. For they hold the memories, traditions, culture and hopes of all the people of these lands and the continuation of cultural, spiritual and educational practices of Aboriginal and Torres Strait Islander peoples. In this session today, we'll be talking about COVID-19, as well as the vaccination program that's just commenced. To help us navigate our way through this very complex subject and understand the issues that are important to us as people with HIV, we have the honour of being joined by Professor Sharon Lewin. Sharon Lewin is the inaugural director of the Peter Doherty Institute for Infection and Immunity, a joint venture between the University of Melbourne and Royal Melbourne Hospital. She's also a Melbourne Laureate Professor at the University of Melbourne and a consultant infectious diseases physician with the Alfred and Royal Melbourne Hospitals, as well as National Health and Medical Research Council Practitioner Fellow. So we're very honoured to have someone so prestigious to talk to us about COVID-19 today. So welcome, Sharon.
Pleasure to be here, Vic. Nice to see you.
Absolutely. So let's just start off with a little bit of background in terms of people with HIV who acquire the coronavirus and the level of risk of having severe illness or even hospitalisation. So what's the latest evidence in that?
Yeah, this has been a really difficult question to answer, and it's because you need big studies that are well designed and also what we say in research, control for other factors, because if we know for COVID you do worse, more likely to be hospitalised, more likely to have death in people that are older, in people that have comorbidities like heart disease, kidney disease, diabetes, etc. And we all know that all those things are more common as well in people with HIV. So when you try and answer this question of what is the real added risk of HIV on top of these other risks like age and comorbidities, what is that number? And different studies have tried it in different ways. The first few studies that were coming out of China were looking at tiny numbers, 4 or 5 people, small case series, difficult to draw any conclusions. Then there was a big study from Cape Town that had much larger numbers, but there were these other confounders of people living with HIV being in a lower socioeconomic group or comorbidities, older, etc. There's been a big study coming out of New York, and then more recently one large study from the UK and then one sort of global WHO study. I won't go into all the details of those studies because there's strengths and weaknesses of each of them. But overall, my take-home message is that the risk of severe disease is increased in people with HIV, probably about 2 times above others. The biggest risk for COVID and severe disease and poor outcomes is age. And none of us can beat that one, unfortunately, particularly once you get over 70 and 80. So we're talking about really much older. And the comorbidities, definitely, they're the things that would be worrying me the most about if I have someone sitting in front of me, if they're 70 and they've got heart disease and kidney disease and diabetes and cancer, and then they happen to be HIV positive. It would be all of those other things that would put them into a high risk group first. But I think overall HIV does increase the risk of maybe 2 times higher. Then you've got the issue of, well, is that only people with low CD4 counts or high all CD4 counts? And there's been some association with more severe disease with people with lower CD4 counts and a greater risk of death in one study with people with low nadir CD4 counts, if they started treatment late. So it's not surprising. People with low nadir and low current CD4 counts do worse with several infections, and it looks like that's the case in COVID as well. So a long and complicated answer to a long, complicated question. Overall, if I could summarise, HIV probably does increase the risk of severe disease at about twofold, not as high as the other risk factors, and a low CD4 count does increase the risk of poorer outcomes.
So for our older people with HIV, why is older age a risk factor? So what is it?
Yeah, it's interesting. There's many infectious diseases older people do worse. It's not uncommon in sepsis, for example, and influenza. Age is often a risk factor for just mounting a poor immune response to an infection. But the association here is striking. Like, it goes from less than 1% mortality at less than 50 to 2 or 3%, 50 to 60, 4 or 5%, 60 to 70, 10% over 70, 20% mortality over 80. So it's a really striking relationship with age. And I think it's a combination of this, not just making a poor immune response to the infection, it might be a sort of dysregulated immune response to infection. And this is we're just teasing this out, but it may potentially be related to your exposure to coronavirus in the past. And in an older person, you've got a greater amount of non-COVID coronavirus interactions, and that may affect the quality of your response when you actually face COVID-19.
It simply be, I guess, the fact that the older you are, you have a less robust immune system.
Yeah, I don't want to overcomplicate it, but it's probably not as simple as that. It's probably that you get a slightly dysregulated immune response to COVID because of your history of having been exposed to other coronaviruses in the past. That's what we're beginning to learn. Actually, older people with, interestingly, and I hope this isn't getting too detailed, but people that are older and sicker make much stronger antibody responses to COVID. I think many people in the community now are well familiar with this idea of antibodies. But we basically make antibodies to infections and they help clear an infection. And of course, the whole rationale for COVID vaccines is to induce antibodies. And we talk about vaccines that make higher and lower antibodies. But interestingly, when you look at just the natural history of COVID, people that are sicker and older have higher levels of antibodies. So it's not just how much you make, it's about the quality and the other arms of the immune system that lead to severe disease. But the relationship with age is really striking, quite different to really any other disease, any other infectious disease.
Okay. In terms of difference between gender. So there's research that suggests there's a difference between men and women in terms of the effect of having acquired coronavirus. Why is that?
Yeah, men do worse, higher mortality rate in men. Not fully nutted out, but when your body sees a new infection, a new virus, there are different arms of the immune system that are called into action. And the first is like the danger signal response. So the minute something lands in your body, you have this, we call it the innate immune system, meaning that it's a very rudimentary part of evolution. Every animal has an innate immune response. I call it like it's danger signal, right? There's something foreign here. And then later you get the other arm of the immune system that's a little bit more sophisticated, that we call the adaptive immune response. And the innate immune response involves something called interferons and other similar molecules, and that is very sex dependent. Men and women make interferon differently, and it's probably related to how you make interferon. We know that to get rid of COVID, a good response to COVID, to clear it, you need an early danger signal response or making interferons. And people that don't make interferons well for genetic reasons or because of sex tend to do worse with COVID. There's quite a lot of infectious diseases around that have got HIV, for example, actually has a different immune response between men and women. and if I get this the right way around, for the same viral load, women have a lower CD4 count, and it's because of this issue of how that first response to a virus.
Mm-hmm. All right. We talked about comorbidities before. So I guess a person with HIV as well as the comorbidities. So what is it about having comorbidities that puts, I guess, a person at higher risk of becoming sick or even hospitalised? So right, we mentioned diabetes or high blood pressure, that kind of thing. So what is it about having a comorbidity?
Yeah, each of them is probably a bit different, and just sort of just to make it clear that most people have very mild symptoms and into COVID, sort of cold-like symptoms or no symptoms, but about 20% of people do land up in hospital, and of those, 5% will end up in intensive care with severe disease, and all of that is related to, it all happens usually 2 to 3 weeks after initial exposure. So, and by the time that happens, there's not a lot of virus around. It's all, your immune system is basically out of control, and that leads to a lot of inflammation in the body and also some abnormal blood clotting as well in the lungs, in the kidneys, in the blood vessels. And so something gets triggered to either because of your genetics or because of your age, that your immune response is not in a nice coordinated way. It's sort of overactive. And I think all those comorbidities just add to that response, and also are, especially the cardiovascular ones, are associated with abnormal clotting in the once that pathway gets triggered. If you have a comorbidity, it gets further amplified. That it hasn't really been teased out in each. Why would diabetes be the same as cardiovascular disease? They're totally different sorts of diseases, but they all just enhance this dysregulated response that leads to severe pneumonia and involvement of other organs.
And that would be of interest, though, because particularly with people with HIV who've had HIV for quite a while and are older, it's quite likely they're going to have comorbidities. So whether it be
exactly,
I've got a bit of high blood pressure, but there is also people with diabetes or other issues. But
blood pressure on its own is not a risk factor. At the beginning, it was thought to be, but it's not on its own a real risk factor. But the others are, and that's why teasing out what impact HIV on its own does to COVID has been quite tricky, because of this fact that people with HIV tend to have, will have increased numbers of comorbidities.
All right, so we've got vaccines now. So in very simple terms, how do these vaccines work?
So the vaccines essentially train your immune system to recognise a little part of COVID-19, so that when your immune system is faced with the real thing, your immune system is ready to go and never allow COVID-19 into any of your cells. That's pretty much the rationale for all vaccinations. So you educate your immune system to recognise a piece of the virus. So when the real virus comes along, your immune system's ready to go immediately and stops the virus ever getting into your body or stops the virus from causing disease. That's a really important distinction. Most people, when they get vaccinated, say against measles or hepatitis B, you basically are completely immune. You don't need to worry. The effective vaccines that are 90+% effective, you don't need to worry about it. But COVID-19's got two bits that we're protecting against. We're trying to protect against ever getting infected, and then we're also trying to protect against getting severe disease. And the type of immune response you need for those two things is a little bit different. And I think that's what can lead to a bit of confusion with the COVID vaccines. But essentially, the vaccines deliver a piece of the virus, not the whole virus in any of the vaccines that we're looking at, just a little piece of the virus. And it's actually this, what we call the spike protein. On the outside of the virus, you've got these little spikes of protein, but like HIV's got envelope protein on the outside. The coronaviruses have spike protein, and the spike protein, it's sort of like, if you think of the spikes like your arm and the very tip of your fingers are the bits that latch onto the cell in order to get in. And what the vaccines do is try and interfere with the virus ever entering into a cell. Mm-hmm. And that's done in different ways. So we've got two vaccines in Australia that are being rolled out right now, the Pfizer mRNA vaccine and the AstraZeneca Oxford adenovirus vaccine. And they're just two different ways that to deliver the little piece of the spike protein to get your immune system working.
And I guess it's important to reinforce that all they do is deliver just a piece of virus that's enough to cause the body to make an immune response. So not the whole virus. Because some people worry about getting, for those who are a bit sceptical, they're worried about being infected with the virus if they get the vaccine. So it's not, they're not being injected with a whole virus, just a small piece, which is not enough to infect, but enough to get the immune response.
Exactly. This is not, you're not being exposed to the virus, you're being exposed to one small part or a protein. Exactly, for example, hepatitis B vaccination, same principle. Just in the hepatitis B vaccination, you don't get exposed to hepatitis B, it's just a little bit of the virus, which is usually one of these proteins that sit on the outside of the virus.
It's interesting. I'm on a Facebook group called TIM, or the Institute of Many, for people with HIV, and I've observed quite a number of posts from people who make an observation that for years we've been working on vaccines for HIV, and it's been taking years, and we're still not there. And all of a sudden, this new virus comes along, and 12 months later, bang, we've got a whole range of vaccines in around 12 months. So why is that? Why is it? What is it? What's the difference? Is it about the virus? Is it about how we work or the research? Why is there such a disparity in the length of time we come up with a vaccine?
Yeah, it's probably a bit of both, but the main thing is the virus. HIV, everyone that gets COVID clears it. People make a good immune response to it, whether you're old or young, and you clear the virus. HIV is the complete opposite. No one can clear the virus spontaneously. So we've got nothing to mimic in the HIV vaccine. We look at elite control. We try and mimic the immune response that the elite controllers make, but we haven't got nature to learn from in HIV. In COVID, everyone clears COVID, so it's a pretty easy virus to get rid of, and basically the vaccine just mimics what happens in natural infection. So firstly, you're starting off with different viruses and how easy they are to clear. And of course, HIV's got this added problem of it being able to integrate into the person's DNA, which doesn't happen with coronavirus. Mm-hmm. But there's no doubt that throwing billions and billions of dollars at a problem with every pharmaceutical company and every person in the planet thinking about it does help accelerate science. There's just no doubt about that.
And there is criticism there from people about, and particularly people with HIV who are sort of feel like they're being hard done by. It's like, why aren't people working so hard on my virus,
Yeah. Well, up until COVID, most people would have said no one has ever invested to the level that we have in HIV. That was probably the best funded virus that we'd ever known about. But COVID has just eclipsed that big time. It's not just about the money, time and investment and commitment. It is also about the science. It is definitely a very different scientific challenge.
Yeah, I think most people understand that. With the vaccine trials, in terms of the various people that were in these trials, when looking at, say, if you can answer this, people with HIV, what proportion were women?
I don't know that answer. All of the big trials have had about 30 to 40,000 people in them, roughly. And all of the big trials that are now out, and by big trials I mean the phase 3 studies that tell you whether the vaccine works or doesn't work, all of them except the Sputnik vaccine included people with HIV. Interesting story. They did at the beginning. They didn't, especially in the US. Moderna and Pfizer did not have HIV was an exclusion, and there was a lot of advocacy. And HIV, there's no reason to exclude people with HIV, and then HIV were included. So a great story. But the number of people was small. So in the Pfizer study, I think there was around 120 people with HIV in a cohort of 30,000 people. So these are very small numbers. And I don't know about the distribution between men and women.
And what about age groups? What kind of spread was there with age groups?
For people with HIV?
In the trials, yeah.
That's not, I don't know that either.
What about in general then?
In general, they're all a little different. So when the studies started, but usually when you first test a new product like a vaccine, if it's not in children and it's in adults, you'll usually go for this safe age range of 18 to 65. That's sort of standard type age range. And so some of the earlier studies had that broad definition. And then it became apparent that you really did need to have more older people in the study so that you could really understand safety and efficacy. You need to have more people of different ethnicities. You need to have more people with comorbidities. And so each of the studies is a little bit different. The AstraZeneca vaccine started early, and they had very limited numbers of elderly people, I think roughly about 10% of people over the age of 65 and very few people over the age of 80. In the Pfizer and Moderna studies, they were making an effort by that stage to get older people, and their numbers are about 25% of people over 65, but very few people still over 80. And we know, for example, here, the over 80 age group is the biggest risk group. So, and so most of the studies now are aiming to get about 25% of their participants over 65. However, we're in an era now that we're not only looking at the studies that led to the licensing of the vaccines, we're looking at real world efficacy, or what we call vaccine effectiveness. You can see how good a vaccine behaves in a trial, and then you put it into a population and you often get different results, how it's working actually in the field. And so in these studies, which are all coming out now, fantastic studies from Israel, from England, from Scotland that have all just appeared. There are lots of people now that are receiving in these studies that are over the age of 80 and receiving the vaccine, because that they're a priority population and often are the first to have received the rollout. So we're learning a lot more now about Pfizer, Moderna, AstraZeneca in people over the age of 80 and over the age of 65 that wasn't necessarily in the initial trials.
And so we're learning it works. Basically, it's safe.
So they're all a bit different. So the Pfizer, there's a very nice publication from Israel, which were very, very effective at rolling out the vaccine. And they published a study of 600,000 people that received the Pfizer vaccine and matched them to 600,000 people that didn't receive the vaccine. So these are huge numbers, because the initial study that led to licensing the Pfizer vaccine was 30 to 40,000. So we're now talking about 600,000. And then they could look at what were the effects of being over 80, what were the effects of having comorbidities, what were the effects of being under 20, being under 50, for example. So they looked at all these risk groups. So overall, what they found was that in the real world, the vaccine behaved just as well as it did in the trial. So that the reduction in they couldn't measure everything, but they could measure the numbers of COVID cases, the numbers of severe cases, numbers of hospitalizations, the number of deaths, and all of them reduced at around 95%. They also showed that people in the elderly, that impact was similar even in the very elderly over 80. The vaccine effectiveness was slightly lower in people that had comorbidities, but overall they found that once you put the vaccine into populations, people did really well. That's actually quite unusual. And usually you do vaccine effectiveness, what happens in the real world never looks as good as the clinical trial, but actually, interestingly, it looks just as good.
That sounds good. And we'll talk a little bit more about that later. But getting back to, I guess, the big question that as we've been asking for a long time is the safety of the vaccine. So people with HIV, I guess, understandably have concerns around the basic safety of getting a vaccine. And I guess one of the things is interactions with our HIV antivirals. So is there any issue around that? Has there any one shown problems or issues with interactions with their antivirals?
Yeah, no issues at all about no issues at all about antivirals. The number of people with HIV in the studies has so far been small, in the range of hundreds, not as opposed to tens of thousands. But there's no signal that the safety profile is different in people living with HIV, and I wouldn't expect the safety profile to be different because this is a part of a virus, and so I would imagine that the immune system it induces and the effects are similar. The main problem with these vaccines is local side effects, so painful arm, bit of aches and pains, fever, headache. That's short-lived, and if needed, will go away with just using paracetamol. The frequency of those adverse effects, of those local effects, is higher with the mRNA vaccines than, say, your regular flu vaccine. It occurs in about 50% of people and can be worse on the second dose compared to the first dose.
And what about the difference between Pfizer and the AstraZeneca? Because that seems to be a question whether there's a difference in the side effects between those two.
Yeah, the side effects of the AstraZeneca are similar, as in local side effects, pain at the injection site, fever, aches and pains, headache, nausea, lower frequency of side effects with the AstraZeneca vaccine, and with the second dose, the side effects are even lower. So those are mild side effects. They occur with both vaccines, lower with AstraZeneca than Pfizer. The one side effect that we are most vigilant for is anaphylaxis, which means a severe allergy to the vaccine. That has only been described with the mRNA vaccines or Pfizer vaccine. Very rare, 1 in 100,000. To put into perspective, penicillin allergies, the frequency of that's 1 in 5,000. This is 1 in 100,000, so very, very rare, and more common in women actually than men. And of those people that have had anaphylaxis, about 85% of them have a history of anaphylaxis or allergy to another product. Even with a history of anaphylaxis, the mRNA vaccine is still safe. The only time you wouldn't use it is if you've had anaphylaxis from that vaccine itself, or anaphylaxis from some of the ingredients inside the vaccine. So if you have had anaphylaxis before, it's important to discuss that with your doctor, the person administering the vaccine, and to see the ingredients. There's a long list of ingredients, chemicals that are inside that vaccine. But anaphylaxis to peanuts or shellfish or something like that in the past doesn't mean you cannot get the Pfizer vaccine.
So there's a good lesson there for people, and I'm running a workshop at the moment. One of the issues we're talking about is having a good relationship with your primary healthcare worker. So, you need to be openly communicating with your, if you see a GP, about any history. So it's really important that the person you're talking to about getting a vaccine, that they're aware of your history, and if you have had any allergies or anything like that, That's a really important.
Yeah, we're talking about severe allergy. Like anaphylaxis means, you kind of collapse, not just you get a bit of a rash or something. Yeah. So most people that have anaphylaxis will carry something called an EpiPen, meaning a sort of a way to treat. You may or may not know people like this, but if you've had anaphylaxis before, you know it because it's really dramatic.
And at the vaccination sites, they're ready for it, aren't they? They're ready for any kind of possibility. Yeah. Talking about people with HIV, and I guess many people today have an undetectable viral load. So for those people who don't know, the viral load is the measure of the amount of HIV in your body, and undetectable basically means that the current test isn't picking up or can't detect an exact amount of virus. It's still there, but it's very low in numbers. Now, there are some people who have a detectable viral load. So for whatever reason, and it may be that their treatments just don't work for them properly or whatever other reason, they have a detectable viral load. So in terms of getting a vaccine, and it may be fine for people who are undetectable, but if someone is detectable, so they might have a viral load, say, that hovers around 10,000 or 20,000, is the vaccine safe? Is the vaccine not going to all of a sudden cause or have an impact on the viral load, basically increasing it? Is there any chance of that happening?
We don't know the answer to that. It hasn't been looked at. I don't think this vaccine would be different to any other vaccine in that respect. And you may theoretically could get a small blip in viral load, but I don't think that would be of any concern and wouldn't be a barrier to getting the vaccine.
All right. And then I guess another nuanced question around particularly women with HIV and getting a vaccine at a particular stage of life, just say, for example, menopause. Is that an issue?
I don't think that would be an issue.
All right. And pregnant women with HIV?
Pregnancy we don't, there's a real gap in the knowledge, So there were pregnant women were not in the large clinical trials. There were a few women that became pregnant in those trials, but the numbers are in like the 20s. So we really don't know a lot about safety and efficacy in pregnancy. Currently about 200 million people, probably even more now, have been vaccinated with COVID vaccines. And most countries do active surveillance of vaccine recipients, meaning they track any adverse effects. So we will learn more about safety in pregnant women over the next weeks to months, I would say. But we don't have that information from the initial studies. What the recommendation in Australia is that the risk benefit should be weighed up in pregnant women. So if you were in a job where you had very high risk of exposure to COVID, we would encourage you to get the vaccine. If you had really no exposure risk, you would probably wait. That's the current recommendation in Australia. There's really no reason that this would be unsafe in pregnancy or that it wouldn't be effective, but we haven't actually studied that.
Mm-hmm. And I guess in terms of waiting, a good thing or good situation that we're in Australia is that we have very low, if any, community transmission, so people can afford to wait.
In Australia, yes.
That's been a bit of a debate too. Why aren't we getting the vaccine as quickly as everyone else in the world? And so, but we need to look at risk, and we have a much lower risk in Australia than other countries where community transmission is much higher in certain places compared to us.
Exactly. Yes, you almost can't compare. I mean, we haven't got coronavirus transmission at the moment, while many other countries are using their vaccination strategies. They're using vaccination to save their hospitals, to get people out of hospital and make a functioning healthcare system again. We're nowhere near that situation. But if you were, working in a airport or hotel quarantine, they're the biggest risk groups now to be exposed.
Yeah. again, in the TIM Facebook world that I'm a part of, like many other people with HIV, there's been a bit of discussion around basically, where are we in the queue to get the jab? So many of us have seen, I guess, a very basic kind of framework that the vaccination program is working in, and we're talking about phases, and phase 1A and B, and then phase 2, etc. And so obviously the very highest priorities, as you mentioned just a second ago, about quarantine workers and people on the borders, border control, that kind of thing. So where are people with HIV? Where are we in the queue?
Yeah, it's not fully determined at the moment, but almost certainly people with HIV will be in phase 1B, which is people that have a coexisting risk factor for COVID.
All right.
And so 1B is most likely where people living with HIV will be. It's being discussed right now, actually, at a government level, so I haven't seen the official final wording. But 1A, as you say, is border and quarantine workers, healthcare workers on the front line, aged care workers and residents, and disability workers and residents. And then 1B is the elderly over the age of 70, and then people with a significant comorbidity, and that's where we think HIV will be.
Because I've read a lot, and I often see the words people with underlying conditions or that kind of thing, which is very vague. It's like, well, does that mean HIV or not? So that's good to hear. 1B is not too bad. I guess a little thing that I've been thinking of, though, and it's only because I'm privy to the research in HIV, where I have often seen where researchers keep telling us that a person of a certain chronological age, and for example, I'm 59, but I keep getting told that my biological age could be 10 to 15 years higher, and that's because of the constant low inflammation levels that I have in my body because of HIV. So, where does that, I don't know if anyone's done any research into that, but, does that have is there an impact there? Do I have anything to worry about if I'm biologically 70? For example.
Yeah, I mean, I've seen no studies that would support that concept, but something that should be studied and will be studied, I think, especially as we look at, say, vaccination responses in people with HIV, which many groups around the world, and we would love to do that here as well. Edwina Wright's leading a study looking at acceptability of vaccination, and we're hoping that we could also build a separate part of that into that study, ability to study people's immune responses to vaccination, and then compare, as you say, a 59-year-old without HIV and a 59-year-old with HIV would be really interesting to look at and how they respond to the vaccine. Those studies will be happening right now, and I hope will also be happening here in Melbourne as well.
All right. Now, how concerned should we be about the variants? Because we're hearing quite a bit about variants, and there's a UK variant, South African, Brazilian, and given that we're okay again in Australia with low community transmission, but the idea that having these variants floating around and having vaccines that may not work as effectively against these variants. So should we be concerned in Australia?
Yeah, variants are definitely something that we have to watch closely, and they are each different and each have different concerns about them. Variants happen because viruses like coronavirus, just like HIV, constantly change every time they infect someone new. In fact, coronavirus varies quite slowly. It's just that there's so many people that are infected, it gives a chance for it to change. Each of the variants that you named are all slightly different, and we also, there's some parts of the information we don't have. So what we want to know about the variants is it more transmissible? Does it cause more severe disease? And are you not protected against the variant, either from prior infection or vaccination? So each of those three things we know to different extents for each of the variants you listed. We know the most about the UK variant, or the variant that was first described in the UK, what's called B.1.1.7. We know that it is more transmissible. We know that it does alter the disease, meaning that people carry the virus for longer and have higher viral loads and probably increased mortality from it. And we know that in studies both in test tube models and in the real world, that the vaccine effects on the UK variant are similar. So the AstraZeneca vaccine works much the same in clinical trials in people with and without the variant. We don't have that data actually for the mRNA vaccines, because the mRNA vaccines were all developed before these variants were on board. But if you look in the test tube model, in test tube tests against variants, the people that received the RNA vaccines, the UK variant doesn't seem to diminish the activity of the vaccine. And South African variant's a slightly different story. We assume it's more transmissible because it became the dominant variant in South Africa, and usually that only happens if the virus has some sort of advantage. Hasn't really been reported yet whether it causes more severe disease or death. And the vaccine studies, we have some clinical trial data and some test tube data. In the test tube data, all the vaccines seem to be less effective against the South African variant. You need higher levels of antibodies, about 7 to 10 times higher levels of antibodies to control the South African variant. That's in the test tube. Now, in the real world, we know a bit about the South African variant. We know about the AstraZeneca vaccine for mild disease. It didn't perform well against the South African variant. It had a far lower efficacy, but we don't know how effective the AstraZeneca vaccine is against disease, which is a different way to measure. We don't know that answer yet. The RNA vaccines in the real world haven't been tested. And then there are two newer vaccines that we haven't yet been licensed in Australia. That's the Janssen vaccine and the Novavax vaccine. And both of them did studies in the US or UK and South Africa. And in South Africa, those vaccines, the efficacy wasn't as low as AstraZeneca, but it was reduced by about 30 to 50%. So the South African variant will have an impact on the efficacy of the vaccine. Though interestingly, and one of these studies comes from Johnson & Johnson, the protection against infection was reduced in South Africa, but the protection against disease was the same. So it still worked well against disease, which is very encouraging. So the immune response that you need to protect against disease when you go to hospital and getting sick or dying is probably different to the immune response you need to stop the virus ever getting inside the nose. So it's an evolving area. There's really very limited data on the Brazilian strain, and now there are these US strains. It's really important that countries have the capability to continually monitor and screen for these variants. You actually need quite sophisticated tools to find them and to study them, something we call genomics. Not every country has a good genomic setup. We've got a great setup in Australia. We pretty much sequence every single virus we can because we've got such limited numbers. We just need to watch this all the time. I don't think it's something people should get panicky about. It sounds very scary. Variants, mutations, vaccines don't work. I don't think people should get anxious about this. It is something that we do worry about, that we actively look for, we're actively testing against. And if needed, and this is already happening, new vaccines can be made to protect against the variants. This is not a really
vaccine can be modified. So
the vaccine can be modified, yeah. You don't need to go and do the whole study again with 30 to 40,000 people. You modify the vaccine, make sure it's safe in a small study, and then you can use it. We effectively do this every year with flu. Every year the flu vaccine is different because it's designed against the variant that was circulating in the season before.
Yeah, and I guess that's It just makes it important that, particularly in Australia, while we're fortunate enough to not have the community transmission, but we do have, particularly people, Australians overseas who want to get back home, that kind of thing. As long as we have that wall up or guard up where we can stop any sort of variants coming through into the community, if we can keep a hold on that or keep doing a good job at that. And again, compared to other countries, we're fortunate that we can do that. Just finally, in terms of, I guess, the experience that people are having overseas with the vaccines. So, we already know that people have had side effects in the sort of medium longer term of having acquired the coronavirus. So there seems to be people that have lingering effects with that. What about people, the very first people with who have been vaccinated overseas? Are there any reports of side effects that have been going on for a longer time from people who've had? And in fact, the question I'd ask is what kind of time period is there now from the first person who's been vaccinated overseas?
So about 200 million people have been vaccinated. The first vaccines would have gone into people in around May or June last year. Long-term side effects of vaccines are really unusual. I can't even think of them that are ones that I know about for our existing vaccines. So long-term side effects of vaccines doesn't really happen. What we are always concerned about is very rare side effects. So if a side effect is 1 in a million, we're not going to, and it's really severe, we need to know about it, even if it's 1 in a million. But we won't find it if you do a study in 40,000 people, because you haven't given the vaccine to enough people to find those really rare side effects. And what we're finding now with the vaccine having been in so many people, 200 million, that there's no surprises. There's no new really rare adverse event that has become apparent with the rollout of vaccines across the world. So that's really good news. And usually if there is some rare adverse event that wasn't picked up in the initial studies, it will usually appear within 4 to 6 weeks of using the vaccine at scale. So we're well past that level, at least with the mRNA vaccines and AstraZeneca, and then the other vaccines have been rolled out. So I don't think we're going to see any new surprises from these vaccines as they go into millions and millions of people. There's no signal at the moment, but it's an area that's activated. Even though we've got all that data from around the world, every person that gets vaccinated is basically on a registry, and if there was any adverse event, it would get reported, so we'd pick it up.
All right. Well, that sounds pretty good. We're in, I guess, in Australia, and we should not only be thinking of Australia, but at least we're a fortunate situation in Australia. And it is amazing, I guess, compared to where we were this time last year. It's just been an incredible journey since the first days and hearing about this virus and then getting really concerned about how easy this virus was being transmitted. It was, people were getting very panicky, but we've been progressing, haven't we? We've been going along and working away and looking at the best mitigation efforts and now with the vaccine. So I guess people can feel a little more relaxed and less anxious that while it's not over yet, and we still need to be, alert but not alarmed, obviously, but we're getting there. Thank you very much, Sharon. It's quite amazing how much information that we've been able to get today. It's really good. So I hope people got something out of that. So thank you very much. And thank you all for watching. If you'd like more information on the vaccine program, just visit the Commonwealth website that you can see at the bottom of your screen. And on behalf of Living Positive Victoria, I'm Vic Perri, and signing off. Thank you.
Thanks very much.